Well, welcome everybody. A beautiful, beautiful fall day in New York City, and just delighted to have all of you with us. You will recall that we're using Grand Rounds as an opportunity to introduce you to new faculty. So in the last couple of weeks, I've told you about Dr. Cavalieri, or Mike Smith did, who's a new faculty in GI interested in motility and seeing patients on West 59th Street. And then last week, we mentioned new faculty, Dr. Bass in endocrinology, who's seeing patients on ACC6. Today, I want to make sure you're aware of Michael Kaplan, who joined us in rheumatology earlier in the summer, seeing patients also on ACC6. Dr. Kaplan completed his fellowship training at Mount Sinai and really has hit the ground running with us. And we've just been thrilled to have Dr. Kaplan. I encourage you very much to consider referring patients to him for rheumatologic disorders. He's a great general rheumatologist, and as I say, really doing wonderful work already for us. We have other new faculty in rheumatology, and I'll share those with you in later Grand Rounds. Today, we're absolutely delighted to have Prabir Roy-Chaudhury with us, who is professor of medicine and co-director of the Kidney Center at the University of North Carolina. Dr. Roy-Chaudhury received his medical degree from the Armed Forces Medical College in Pune, India, completed a master's in pharmacology and a PhD in renal medicine at the University of Aberdeen in Scotland, and then completed his residency in internal medicine at the University of Cincinnati and his fellowship in nephrology, where he was side by side with a good friend of ours, Ira Meisels, at Beth Israel in the Harvard system. Dr. Roy-Chaudhury started off his career at the University of Cincinnati, and for a number of years now have been at the UNC. And it was really a delight for me, Dr. Chaudhury, to review your remarkable career. And he's made impacts in two important areas in nephrology. One, in transplant nephrology and helping us to better understand antibody-associated rejection and how to manage that. And then importantly, and I think this will resonate for everyone in the audience, and particularly for our house staff, trying to ask an important question that in many respects have never been asked. Why is it that grafts fail as frequently as they do? And he's done so much to help us understand the biology of dialysis graft failures, the risk factors associated with those failures, of course, the treatment, and most recently using AI and big data to really help us get our arms around it in a much broader way than we have heretofore, and has done remarkable work. He's known internationally and has done important work as a scholar and invited lecturer across the globe. And I think it very significantly trying to bring new technologies, affordable technologies, to emerging economies in places like Africa, for example, and parts of Asia. So Dr. Roy-Chaudhury, it's such a pleasure for us to have you here today. He is a fellow of the Royal College of Physicians in Scotland, and really a remarkable scholar and contributor to our understanding of kidney diseases. And again, thank you so much for being with us.
Not at all. Dr. Seward, thank you so much for that very, very kind introduction. I just wanted to confirm that all of you can hear me well and that you can see the slides well. And I see Angad nodding. So I'll go ahead. I really wanted to start off by saying that, and this is to the house staff and I guess to the junior faculty as well, that one of the good things about residency and fellowship training is that you make really good friends. Ira Meisels and I met first on July 14th, 1993. So that's almost 30 years. And, you know, we remain really good friends. We've been to our kids, well, our kids are not married, but Ira's daughter is. And so I think that's just special. And sometimes it can feel really busy and you're running around here and there. But I think that sort of environment does make good friendships that, I definitely have treasured. And it is, I would say, it's always a pleasure to speak at a place where you have friends. And I consider Ira as just a wonderful friend, and I was going to say colleague, but he's a friend, not a colleague anymore at first, completely. So having said that, the talk that I'm going to give today actually is not going to focus that much on the two areas that Dr. Seward identified that I've been interested in. But I really hope that it is a presentation that opens your minds to a number of different things, some of which are related to medicine and others are not related to medicine. And even though I will use the kidney as an example, I think it's really important to understand that what I'm going to describe in this presentation could be applied to any field of medicine. And then finally, again, just thank you, Angad, and thank you, Dr. Seward, for this very kind invitation. So with that, let me move forward. These are my disclosures. And what I'm going to do in this presentation is that I'm going to divide it into three main parts. I'm initially going to point out to you the huge need for patient-centered innovation in kidney diseases. And again, I believe that's in every disease. I'm going to describe to you some examples of patient-centered innovation within a couple of public-private partnership organizations that I have been involved with. And then finally, I'm going to end with a message for the future. I want to start off, however, with a very, very clear message for the present. And that message, and I know that you all see it in your practice, whether as internists or as house staff, that there is a lot of kidney disease. 850 million people worldwide have kidney disease. 37 million of them are in the United States. And the total cost of kidney care, which includes in this country, $35 billion for really hemodialysis, is $114 billion. So the reason that these numbers are important is, and this makes it really a global issue, is that it's really impossible for average citizens to bear this sort of cost, $89,000 a year in this country for a year of hemodialysis. For industrialized nations, this is a huge drain on the exchequer. So $114 billion is actually 20% of the entire Medicare budget. That's just spent on one relatively narrow but very important specialty. But the problem is bigger than that. And I know that you're an international audience here, but for emerging economies, it's just not possible to provide kidney care or end-stage kidney care in particular for everyone. Now, if you dive a little bit deeper into what I've termed as a crisis in kidney diseases, you've probably heard of many of these statistics. There are over 500,000 Americans on dialysis currently, actually on hemodialysis currently. And even though we spend a huge amount of money, the value that we get is actually really poor. At the end of 5 years on hemodialysis, only 41% of patients are alive. And yet I would argue very strongly that these are the lucky people because they live in industrialized economies where dialysis is available. The bigger problem by far is about the worldwide disparities in kidney care. So if you look at actually, let's start off with the right panel. If you look at the right panel, in 2020, there were about 3 million people receiving end-stage kidney disease therapy. And that's good. And that number was actually going to rise to 5.4 million people by 2030. But the real statistic is that even though these 3 million people were receiving dialysis in 2020, over 8 million people actually died because of a lack of dialysis, mainly due to economic reasons. And then if you look at the left panel, the point that I wanted to make is that it's actually 6 billion, not 6 million, but most of the people on this planet live in countries, so China, India, Africa, the Middle East, within this circle. And the colors of blue or the shades of blue indicate the prevalence in patients per million for end-stage kidney disease care. And dark blue represents that you have a lot of people receiving end-stage kidney disease care. The light blue circles, the light blue indicates very few. And of course, the message is that most of the people, most of these 8 million people actually are in these countries where dialysis is not available. And in 2021, that's not so much because of a lack of technology. It's really, in most places, an issue of cost. Let's move away from those global comments and sort of really ask why in this country and in many other countries around the world, where we have such a poor survival on hemodialysis. And if you look at the right panel, you can see that this 5-year survival of 41% that I spoke about is actually far worse than pretty much every form of cancer that's out there, except perhaps for occasional, except for some forms of pancreatic or lung cancer and some hepatobiliary cancers. And many of us would argue that one of the reasons for this, and I'm extending this now to chronic kidney disease as a whole, is that there's been relatively little innovation in the kidney disease area. So if you look at the left part of this slide, you see that there are just about 8 new drugs that have come out focused completely on kidney disease in the last 10 years. And of course, if you compare that with oncology, it's going to be something like 8 drugs every couple of months. I sometimes look at the New England Journal of Medicine and I see all these oncology studies, and it's sort of like the New England Journal of Oncology. But that's a good place for a specialty to be in. That's where very clearly we would like to be in when you're talking about kidney disease. It's not just about drugs, right? Dialysis or kidney disease is a technology-rich area. And the panel on the left shows you a patient on dialysis in 1965, so over 50 years ago at the Royal Free Hospital in the UK. And then on the right, a more recent picture. And the message that I very clearly want to put out to all of you is that the basic construct of dialysis has really not changed over the last 50 years. So yes, there are bells and whistles. There's been some miniaturization, but the basic construct remains the same. Now, I want all of you to keep this picture in your mind's eye as I go to the next picture, which shows you the changes that have occurred in another technology-rich area of really life in general, which is computing. And I would completely argue that any of the little devices that every one of you hold, and I hope that you're looking at me and the screen and not at your cell phones, but any one of these little devices actually has more computing power than the large IBM computer on the left. And so the challenge, and in many cases, this is not just for kidney disease. I think there are other areas lots of areas in medicine that have similar situations. But the challenge really for end-stage kidney disease care, and I would say CKD care as a whole, is that we provide really poor value in that we have a poor outcome on hemodialysis in this case, and we spend a huge amount of money really in order to achieve these poor outcomes, which really doesn't make sense. And I will say that we are beginning to be in a sweet spot for kidney disease. We're all excited about some of the new drugs that initially came out for diabetes, but clearly have cardio-kidney effects. But again, I think there's a long way to go, particularly in the end-stage kidney disease population. The one point that I will say about poor value, and I think the next slide is a really important slide, and like many of my slides, it's absolutely not from the medical literature. So I would encourage you to read outside of the medical literature, because it's at the end of the day, it's about life. But the only saving grace, perhaps, for end-stage kidney disease is that the rest of the country is actually doing, in a way, if you look at it globally, almost just as bad. And I really want all of you to just think about this slide. And what it shows is that on the x-axis, you've got health spending per person at $2010 in terms of purchasing power parity. And then on the y-axis, you've got life expectancy. Now, how do you measure the overall quality of health in a country or a region. It's difficult, and there are problems with life expectancy, but it is the sort of one constant that's out there and is often used. And the message is this: in 1980, which is actually when, and again, I don't want to go too much into politics, but this is at the start of the Reagan years, when there was a shift in general in overall policy in this country in terms of how much government plays a role in healthcare. In 1980, we were about in the same place, although at the lower end of the other 18 OECD or industrialized countries. But since then, if you look at Japan or Germany or Switzerland, healthcare costs have gone up maybe 1.5 times, and life expectancy has actually gone up quite significantly by about 7 years. If you look at the US from 1980 onwards, the slope really shows that life expectancy has only gone up a little bit. Costs have expanded exponentially so that they're about 3 times as much as the rest of the OECD. And the tragedy, of course, is, and some of this was due to the opioid epidemic in this date, and obviously now you have COVID, but between 2016 and 2015 and 2017, the costs of healthcare per capita went up by $1,000, but life expectancy came down by a year. So this is just something that I think all of us in healthcare, regardless of specialty or age, I think should keep in mind. It affects all of us. So with that digression, let's get back into nephrology. And I think the problem with kidney disease, of course, is, well, how do we break this cycle of poor value in ESRD care, which is really, in my mind, due to a lack of innovation, resulting in poor quality, resulting in a high cost burden, and then the cycle goes round and round. And I would argue very strongly that one way that we can break this cycle or try and break the cycle is through patient-centered innovation. So what exactly is patient-centered innovation? This is innovation that really targets the things that are important to patients, not necessarily the things that are important to many of the other stakeholders in this area, which would include physicians and industry partners and healthcare organizations and federal agencies. And the fact that there are two different worlds is really brought out by this slide. And again, I would encourage all of you to think about this in your own fields. And what it shows is, it shows the things that are important to patients in the right part of the slide. And these are patients on hemodialysis. And what patients on hemodialysis said is that the ability to travel and dialysis free time and not feeling washed out at the end of dialysis were the things that were important to them. But when you spoke to the physicians that were looking after these same patients, you got some very different answers, as shown in the left part of this panel. So physicians, nephrologists here, were concerned about death and mortality and blood pressure. So we're nephrologists. We obsess about whether the blood pressure is too high or too low or just right. But that wasn't really that important to patients on hemodialysis. And I think that is something that all of us, and this is across different fields, should really keep in mind as we go about our practice. So then the next question is, well, how do we develop new therapies that address the issues that patients feel are important? And this is a slide that I got from Frank Hurst, who's a nephrologist, but at the FDA. And it basically makes the point that the way to do this is to incorporate patient input at every point in the total product life cycle of new drugs, all the way from initial ideation to clinical trial design to patient preferences to the actual use of patient-reported outcomes when you're talking, for example, about clinical trial endpoints. Now, it's easy to put up a diagram like this, right? But just saying that this is important doesn't really make it so. And so one of the things that I've been very involved in over the last now 8 years, and I would say expanded my mind and changed the way that I think about medicine is that I've been involved in a public-private partnership called the Kidney Health Initiative. It's between the US FDA and the American Society of Nephrology, and it was formed 9 years ago now through a memorandum of understanding between Ron Falk, who's actually now my boss at UNC as the chair of medicine, and Margaret Hamburg, who was the then FDA commissioner. And I want to recognize Patrick Archdeacon, who's a nephrologist, but at the FDA, for really playing a huge role in starting off this partnership. And its goal was really to promote innovation in patient safety in kidney disease. So really try and get more therapies rather than just those 7 or 8 therapies that are out there in the kidney space. The way that I've always looked upon the Kidney Health Initiative is that its goal was really to create a pre-competitive innovation substrate, if you will, that would facilitate the passage of novel therapies, drugs, devices, biologics into the kidney disease space. At the present time, the Kidney Health Initiative is a multidisciplinary collaboration of over 100 organizations, and that includes industry partners and health professional organizations and lots of patient organizations, and also very, very importantly, many federal agency members. So it's not just the FDA, but NIH and CMS and CDC are all members of the Kidney Health Initiative. The other thing that's really important about the Kidney Health Initiative is that we have an extremely active patient and family partnership council, which really makes sure that everything that we do in the Kidney Health Initiative keeps the patient front and center. And again, I'm going to give you a personal anecdote. When we started off the Kidney Health Initiative, it was sort of really pushing the envelope and sort of groundbreaking to even consider that we should have a patient on some of the committees in kidney disease as a whole. And I'm very, very proud of the fact that currently in the kidney disease area, this has actually just become, it would be, there are very few major or important committees or initiatives that do not have patient input in the kidney disease area. And clearly this could be in other areas and is in other areas as well. But I'm very proud of the fact that we really, I think, have a very robust patient involvement. That's not just lip service. That's the important thing, right? That's not just lip service in the kidney disease area. So what does the Kidney Health Initiative actually do? And again, this is far from kidney disease in a way, it's policy. But what the Kidney Health Initiative wants to do is that it does different projects. And we've done 18 projects to date. And our projects have been in 4 main areas, really, because we don't have any biomarker projects still. But they include patient and family partnerships, a closer collaboration with the FDA, and then very, very importantly, projects on clinical trial endpoint and design and on clinical trial infrastructure. And our goal very, very clearly is that we hope that the output from these projects, be they white papers on what the right clinical trial endpoints need to be, or data standards, or workshops, or roadmaps, at the end of the day, these are all projects whose output will facilitate the passage of drugs, devices, and biologics into the kidney disease area. And again, I'm sort of going to give you an anecdote. When I was younger, it was all about diagnosis and treatment. And the new therapies, they just appeared, and that was exciting. And sometimes they didn't appear. But in reality, there's a whole process to get new therapies onto the market. And it's actually a little bit of a jungle out there in the industrial world or in the pharma world, because if you have a new product, for example, an anti-inflammatory small molecule that could work for Crohn's disease and ulcerative colitis, that could work for rheumatoid arthritis and also for lupus nephritis, the product is going to be developed for that particular area where you have a well-defined regulatory and, very importantly, reimbursement pathway. And we just didn't have that in kidney disease, and we didn't have new therapies coming into kidney disease. And I think that particularly for some of the glomerular diseases, I think things have really changed. We have new therapies coming in, and in a small way, or maybe in more than a small way, I really think that what the Kidney Health Initiative has done has helped with that. And that's, again, that's about really making an impact, trying to change things. And again, for all of you in the audience, particularly for the residents and fellows, it is about making an impact, and there are many different ways to do that. So with that sort of broad overview about kidney disease and innovation, I'm going to focus down on one particular project within the Kidney Health Initiative that I think will give you a feel of what we're really trying to do, and that is the creation of a roadmap for patient. I'm getting a letter. I'm getting a message. Wonderful. I will address that. But what the roadmap actually does is that it's an example of a project that really puts patients first and tries to change things in kidney disease. So the roadmap for innovative renal replacement therapy basically addresses the same problem that we spoke about earlier, right? This vicious circle of a lack of innovation, poor quality, and high cost burden, particularly for hemodialysis. Now, I will say that if you want to look at the future, I think you have to sort of study the past, right? That's very important. At a personal level, I love history. I would have become a historian, I think, if I had not grown up in India in the 80s, when you either became a lawyer or you became an engineer. I see Angad smiling a little bit. But dialysis really started off at the end of the Second World War in a small town in the Netherlands called Kampen. The pioneer who's shown on the left was Willem Kolff, who at that time was a young individual. Dr. Kolff, Pim Kolff, he was called, passed away in 2009. And right in the middle of the screen, you see the first dialyzer that he really created. And it was basically a wooden drum. And around the wooden parts of the drum, he put cellophane or sausage skin, actually, instead of cellophane. And then he passed the patient's blood through the cellophane that was wrapped around. You can actually see it wrapped around over here, around the wooden drum. And then, so the blood went through the cellophane, and then he rotated the drum basically in the stub, which was filled up with the dialysate. And he dialyzed 13 people, and 13 people consecutively all died of acute kidney injury. The 14th person was the lady that you see here on the right. You actually see the curve of the blood urea. So 396 would mean about 200. And at the first dialysis, you see this huge, very, very impressive drop from this would be a BUN of 200 to about a BUN of 60, and then some repeated dialysis, and then her kidneys kicked in. So again, the message is, you got to be persistent, and Dr. Kolff definitely was persistent. There's another part of here. A couple of other interesting anecdotes. When this lady woke up, and this was really poisoning because of a mercury-derived diuretic, the first thing she said was, "I'm going to divorce my husband." I'm told that this is absolutely true. But there's another part, there's another interesting story as well. And again, this shows you that medicine and life are often intertwined. Kolff was an amazing man, because at the end of the Second World War, he sent out his dialyzers to 4 countries. He sent them to Canada, to the UK, to the US, and to Poland. And these 4 countries, again, historically are important. These are all countries that contributed to the freedom of the Netherlands at the end of the Second World War, right? And so Poland is in there because there were Polish soldiers who went in and were part of the Allied forces that came into Europe at the end of the Second World War. So again, very different from the world we live in right currently, right? IP, intellectual property, venture funding. He just gave away a huge advance in medicine. So a great man. Again, on the same premise of if you want to change the future, you need to know the past. What Kolf did in the previous slide was about acute dialysis, right? But for chronic dialysis, you need some sort of vascular access. It's still a problem. I will say this. And I have another talk, which is totally around vascular access. But chronic hemodialysis became a reality with the Scribner shunt that came out in 1960, which was basically this connection which was outside the body between the artery and the vein. But when the Scribner shunt came out and chronic hemodialysis became a possibility, a reality, there clearly weren't enough dialysis machines or dialysis centers. And so the whole issue came up, who will live and who will live and who will die. And so there were these death panels, they were called, that were created that actually decided who would actually get onto dialysis. And they considered things like education and social work and contribution to society. So again, in our current environment, this would be unthinkable, but this was the reality in the 1960s. And I would argue very, very strongly again that this is still the reality for so many people. This is still the reality for the majority of the world's people with end-stage kidney disease. And it's not so much about whether you get dialysis or not is not so much about social worth. It's really about whether you have the ability to pay when you're in a country or a region that doesn't have a public health system that supports dialysis, which is not there in most parts of the world because it's so expensive. We've come a long way, though, coming back now to the United States since the 1960s. The death panels are long gone. Hemodialysis is now routine. There are lots of people on hemodialysis in this country. And even though I have been critical of my own specialty, which is what all of you should do, whichever field of medicine you're going to, I'm also proud of my specialty, because whatever you say and whatever the problems are, dialysis remains at the present time the only reliable and long-term form of organ replacement therapy. That's we're not talking about transplantation here. And I think we should be really proud of that. I think to some extent, the fact that we had this cure, this artificial kidney, if you will, so early on has made all of us and all of you complacent, because if you have kidney failure, well, there is dialysis, at least in this country. But what we've forgotten when we're talking about dialysis is that we've forgotten about rehabilitation. And what Dr. Kolf said so many years ago was, and again, this is a prescient statement. He said that if the treatment of chronic uremia cannot fully rehabilitate people, then that treatment is inadequate. And I think along the way, we just forgot about this statement, because I would argue very strongly that at the present time, dialysis keeps you alive, but it doesn't really allow you to live. It doesn't really allow you to do the things that you want to do, because you're washed out and you're in the unit three times a week. And so the goal of this renal replacement therapy innovation project of the Kidney Health Initiative was really to create a roadmap for innovative renal replacement therapy. And any of you can go to the website, and if you put in KHI technology innovation roadmap, this will come up. There are lots and lots of details within this about a roadmap strategy, which goes all the way across the continuum from enhanced dialysis to portable and wearable dialysis to a biohybrid or implantable kidney. And I'll show you some examples to finally being able to regenerate a kidney. So there's a technical plan that's extremely detailed that we hope will serve as a catalyst for innovation. But the most important thing by far about this roadmap is that it emphasizes time and again that whatever new therapy, something like your cell phone that allows you to do dialysis if it's strapped on to your arm maybe, but whatever comes out, and we don't know what will come out, that it has to improve the quality of life of patients. It has to improve their ability to work and travel. It has to reduce their medication burden. It has to liberalize their diet and the fluids that they can take. It has to reduce the number of interventions and hospitalizations that they have to undergo. And again, all of you know, dialysis patients are in hospital all the time. We're not doing a very good job. And then most important in most parts of the world, and definitely even in this country, is that it has to be a therapy that reduces the financial impact or burden on our dialysis patients. Because, you know, an absolute truth across every country on this planet is that chronic diseases drive you into poverty. And there isn't a chronic disease that does this better than kidney disease. So, and again, please do remember, this is a huge problem with chronic disease. It's a problem in this country. It's a problem all over the world. The other thing that the roadmap does, which again is not so much technical, is that it spends a lot of time and emphasis around creating a regulatory and reimbursement pathway for these new therapies. And that's important because you could have the best idea, the best biology, the best drug or device. But if you don't have a regulation and reimbursement pathway that allows you to get this new product, drug, device, biologic into patients, it's never going to get to patients, right? So it's a lot more than just biology and clinical trials. You have to have this product development pathway as well. And the roadmap really emphasizes that. So at the end of the day, what we see the roadmap doing is that we see it really serving as a catalyst to enhance innovation in this field. We hope that it will generate interest from industry and academia. In particular, we want people from outside of the medical world, engineers, physicists, chemists, to enter the field of kidney failure and bring their innovations in. And again, the example that I like to give is that, you know, dialysis is all about filtration. So if there's a company out there that has really good technology in filtering seawater, and actually we have a group at UNC that can do that, we want that sort of company to come to get into the business through this roadmap initiative of filtering blood, right? Because that's really what we need. And at the same time, we have to be sure that whatever comes out is both commercially viable and patient-centered. And I sort of speak about the 3 I's to change things, bring new therapies in: interest, investment, and innovation. And I think you really need all 3 of them. So this is a really important slide. So everything that I've spoken about the roadmap till now has really been in terms of a technical roadmap, a pathway for regulation and reimbursement. But if you think about a patient on hemodialysis, this is a roadmap to freedom, right? It's a roadmap that's going to take somebody who's stuck in a chair with in-center dialysis. And if you can have portable dialysis, it's going to make their life more normal. It's going to allow them to travel, do the things that patients really want to do. And if you have this implantable kidney, then suddenly you could be leading a normal life. And when you think about freedom for a dialysis patient, we're really only limited by our imagination. So this is a picture of a dialysis patient from Seattle, where dialysis first started. Bill Peckham, he unfortunately passed away about 2 years ago. And here he is rafting down the Colorado River in the middle of the Grand Canyon. But he was unique. And this is available to 0.000001% of patients on dialysis. But why can't more patients with kidney failure actually have this freedom? I also want to emphasize, and as Dr. Seward said, I grew up in India. It's really important to make this roadmap a global consortium, and we're really trying to do that through a number of different initiatives. But that allows me to sort of speak for a few minutes about end-stage kidney disease in emerging economies, and just a couple of messages. The first message is that most of the growth in end-stage kidney disease, and this has increased greatly from 2013 to 2021, is going to be in emerging economies. So here you see 2000 compared to 2013. And this makes sense because as because most of the people on this planet live in emerging economies. And as emerging economies, India, Brazil, China, Indonesia, become richer, there is, as per capita income increases, there's a greater chance of patients or more patients in those countries getting onto dialysis, so the government actually investing in kidney replacement therapy. But I just want you to focus a little bit on this slide, which really brings out still the stark reality in most of the world. So if you look at the US, the incidence of end-stage kidney disease, so if you have 1 million people in any 1 year, 370 in the US will develop end-stage kidney disease requiring hemodialysis, peritoneal dialysis, or a transplant. And that incidence in India is thought to be 180 overall. And I think that's probably less than it truly is. I think it's somewhere in the region of 250. And the reason for the lower number is that there's more diabetes and obesity in the US. That's the incidence of end-stage kidney disease. But if you look at the number of people on dialysis, when you looked at incidence, there was a twofold difference in incidence. When you look at the number of people on dialysis, there's a 40-fold difference. And that's really because the resources to dialyze people are really not there in most parts of the world. So that's the reality that is still out there. And I would just submit to you that in many ways, the industrialized country model of dialysis, which is expensive, that needs huge amounts of purified water, needs infrastructure, it doesn't really make sense for many parts of the world. I think we're looking for something in an ideal setting that's cheap and sturdy and portable and battery operated, that regenerates its dialysis. So basically you can get 3 liters of bottled water, put it into a machine, and then the water is used for dialysis, but then you keep taking the bad stuff out of the water. The technology is actually available. It's a question of really getting it into patients at a cost that is cheap enough. And again, my hope is that maybe we could sort of have a cell phone analogy for kidney disease. In other words, could we leapfrog 2 generations of dialysis care through real innovation that creates a kidney replacement device that provides state-of-the-art therapy at a reduced cost? And clearly, in order to do this, you need discovery innovation, but you also need process of care innovation, payment schemes, public-private partnerships, vans that go around with dialysis machines, and innovative forms of insurance. We won't know until we try, but I think in many parts of the world, this sort of innovative process of care to get kidney replacement therapy to patients is now beginning to happen. So some messages from this part of my presentation, and then very quickly, I'm going to run through some new innovations. But the 3 messages from this part of the presentation is that if you want to have new therapies, you need to create an ecosystem for innovation that has to go all the way from biology to technology to patient care, and it has to include things like regulation and reimbursement. The second message from this part of the talk is that it's really important to get people together, right? That's the big message from the Kidney Health Initiative. So significant progress can be made if you provide a platform or a meeting place for collaboration, partnership, in this case, between government and industry and academia and patients and regulatory and reimbursement agencies. And that's what the Kidney Health Initiative is trying to do. And as all of you go out into your careers, please remember that getting different types of people together is what makes the difference. It's also fun. It's fun because you get exposed to all of these different ideas that otherwise you would not have thought about. And then the last message, and this was given to me, I was introduced to this African proverb by Murray Sheldon at the FDA. And it basically says that if you want to go fast, go alone. If you want to go far, go together. And in the kidney innovation world, we want to go far. We want to be disruptive. We definitely don't just want to build a better dialysis machine. And in order to do that, we really need to go together. So with that, I'm going to go very quickly into the second part of my presentation, and I'm a little bit short of time, so I'm going to skip some slides. But the question is that do we actually have the science to do all the things that I spoke about? And the cartoon says I'm a fiction writer in the grant proposal genre. Now, that's not bad if you can actually do it, but can we do it? And I think we can do it. And I'm just going to show you some very quick examples. This is an example of a patient with a wearable artificial kidney. So this technology is out there. It's been tested in patients. Victor Gura on the right has been the pioneer. And that's pretty neat, right? You could, yes, it's bulky now, but hopefully it'll get miniaturized. So that's a potential for the future. Another thing that's got a lot of press is an implantable bioengineered kidney. And so what this comprises is that you've really got you've got something about the size really of your fist that's connected to an artery and a vein into your bladder. And it's made up of lots of silicon membranes or silicon nanomembranes for the filtration part, but then you've got tubular cells layered over this so that you can have the reabsorptive capacity. And this has actually been placed into a pig. You see the actual device, and this was given to me by my good friend Shubha Roy at UCSF, who's been a pioneer here. And they've been able to demonstrate that you can actually, over a short period of time currently, actually get some clearance. So this is not that far off. And I'm going to skip through these slides. There's a lot of interest in the area of kidney organoids, for example, and you can tweak cells currently, induce pluripotent stem cells to do amazing things. And so on the left panel, you actually see this kidney organoid, which has an afferent and efferent arteriole. And then over here, you see the glomerular tuft, and then you see the podocytes around it. And what's really interesting is that these organoids can sometimes on their own come together. So again, maybe that could allow for kidney regeneration or for creation of an artificial kidney. So with that, I want to end with a number of messages for the future. So the first message, and this is an important message, is that patient-centered innovation, and this could be discovery innovation or process of care innovation, is absolutely essential if we want to address the issues that are important to our patients. We really need to involve patients at every step in the product development process. And again, at a personal level, what I do want to say is it's the right thing to do. And please do remember, and this is more and more obvious as I grow older, that at some point in our life, we will all be patients. And also remember, and we'll speak about this in a moment, that equity in healthcare matters. So I thought about how, in a very short time, to tell you about how do we involve patients in innovation. And I ended up saying that I'm going to show you a video that was created by an individual that I will tell you about, but I think it really brings together how exciting and important it can be to have patients involved in innovation.
Hello, I'm Cece, a fellow kidney disease patient. For 33 years,
you can hear it, right? I'm good.
Both chemo and PD. I had a transplant for 10 years, and as you can imagine, too many pills, shots, and accesses to mention. As kidney patients, you and I both know that a few things in life are not optional. Strength, courage, persistence, and determination. No matter what life throws at us, we try to stay balanced, maintain our routine, and remain positive. But let's face it, we are often in a holding pattern. Kidney disease treatments have not changed much over the years. The options for patients like us have largely remained the same for many years. You want to help change that? We need you. Each day we're asked to share our lives with our treatment. But now let's share our voice, ideas, opinions from patients like us. They matter. Key people are realizing our voices matter too. Here's what I found out. The Food and Drug Administration, often known as the FDA, is looking for patients living with kidney disease, like you and me, to provide input on how potential treatments of the future could look. Picture a big table. Around it are dialysis caregivers, researchers, doctors, nurses, and companies providing new products and treatments. They want us and our families to sit beside them and have a seat at this table. We'll work together to bring potential new treatment options, safe and effective ones, and ones that patients like you and me want and need. Imagine the future of your treatment. What does it look like? How does it improve your day-to-day life? This future doesn't have to remain just a dream. Join me and other patients to contribute our thoughts and make our ideas a possible reality. This is my invitation to you. Lend your voice and work with the people who can help make it happen, with one shared goal, living better with kidney disease. To learn more about how to share your voice and work with people to help make it happen and sign up for a webinar, go to Kidney Health Initiative.
So I've always felt that that was a very powerful video, and the voice in the video and the ideas in the video all came from this lady, Celeste Lee. She was a member of the Kidney Health Initiative Board of Directors. She was a champion for placing the voice of the patient front and center in kidney disease. And she died about 3 years ago. And she died because after 25 years on dialysis, her bones were brittle and her sternum, in fact, just collapsed onto her heart, really, and she decided to stop dialysis. And I've always felt that, I think Celeste's death really should be a charge for all of us to try and develop therapies that target the things and the issues that are important to patients. The next message that I want to really end with is about innovation. Actually, one more message after innovation. So the message about innovation is that, of course, innovation needs ideas and resources, but even more than that, I think it needs the 3 Ps, right? It needs passion and patience and persistence. But what I also want to say is that in innovation, as in life, you really have to believe. And my next slide is really a video from a children's book, which is really about ideas and innovation. My next video.
What do you do with an idea? One day I had an idea. Where did it come from? Why is it here? I wondered, what do you do with an idea? At first, I didn't think much of it. It seemed kind of strange and fragile. I didn't know what to do with it, so I just walked away from it. I acted like it didn't belong to me. But it followed me. I worried what others would think. What would people say about my idea? I kept it to myself. I hid it away and didn't talk about it. I tried to act like everything was the same as it was before my idea had showed up. But there was something magical about my idea. I had to admit, I felt better and happier when it was around. It wanted food, it wanted to play. Actually, it wanted a lot of attention. It grew bigger and we became friends. I showed it to other people, even though I was afraid of what they would say. I was afraid that if people saw it, they would laugh at it. I was afraid they would think it was silly, and many of them did. They said it was no good. They said it was too weird. They said it was a waste of time and that it would never become anything. And at first, I believed them. I actually thought about giving up on my idea. I almost listened to them. But then I realized, what do they really know? This is my idea, I thought. No one knows it like I do, and it's okay if it's different and weird and maybe a little crazy. I decided to protect it, to care for it. I fed it good food, I worked with it, I played with it, but most of all, I gave it my attention. My idea grew, and so did my love for it. I built it a new house, one with an open roof where I could look up at the stars, a place where it could be safe to dream. I liked being with my idea. It made me feel more alive, like I could do anything. It encouraged me to think big, and then to think bigger. It shared its secrets with me. It showed me how to walk on my hands, because, it said, it is good to have the ability to see things differently. I couldn't imagine my life without it. Then, one day, something amazing happened. My idea changed right before my very eyes. It spread its wings, took flight, and burst into the sky. I don't know how to describe it, but it went from being here to being everywhere. It wasn't just a part of me anymore. It was now a part of everything. And then I realized what you do with an idea. You change the world.
So we've spoken about patients, we've spoken about innovation and ideas, and the last message is really about equity. So over 50 years ago, Martin Luther King said, of all the forms of inequality, injustice in healthcare is the most shocking and the most inhumane. And I would argue that 50 years on, this inequity has actually increased, particularly when we talk about kidney replacement therapy at a global level. It's clearly there in the treatment of kidney diseases in the US. And I think the COVID pandemic has really torn the lid off the huge disparities in healthcare. The things that we need to do as we go into this area of new devices and new therapies is to make sure that minorities, vulnerable populations are included in clinical trials. We need to make sure that new drugs, new devices that we're also excited about, I'm excited about, are available to all. And I think one of our biggest challenges is going to be, how do we make sure that innovation actually reduces, as opposed to, how do we ensure that innovation reduces rather than enhances disparities in kidney care? And again, this is larger than just medicine, but it's what I think we move towards as a society. And again, if we're going to do this, we need to do this together. So with that, I just want to thank, in particular, a lot of people in the American Society of Nephrology and the FDA for their support of many of the things I've spoken about. I want to recognize Melissa West, who was the project director for the KHI. And again, I really want to thank you, Dr. Seward and Angad, for this very kind invitation. We've got 4 minutes left. I was hoping to have a bit more, but I'd be more than happy to take questions. So thank you again for the invitation.
Thank you so much, Dr. Roy-Chaudhury. Yeah, we have about 4 minutes left for question and answers. We have a question in the chat from Dr. Braun. So she says, how much does the physiological yo-yo with HT play a role in patient perception of wellness? And how many chronic HT go on to transplant?
Yeah, so both very good questions. I'll answer them quickly. I think that it is totally unphysiological to do what we do to dialysis patients, to compress 168 hours of a functioning kidney every week into 12 hours. The fluid shifts are huge. They could contribute. The electrolyte shifts are huge. I think they are likely to contribute to the feeling, particularly the fluid removal is likely to contribute to people feeling washed out. And we absolutely need to go towards doing more dialysis at home. And we need to be moving towards doing continuous dialysis. And I know this is a long answer, but it's I want to add that I asked 100 nephrologists at a meeting once, if you had kidney failure, how would you dialyze? And the answers were transplant, PD or home hemo, and in-center hemodialysis right at the bottom. You ask those same nephrologists, how do you dialyze your patients? It's the opposite. In-center hemodialysis, followed by peritoneal dialysis and transplant. Yes, I agree with that. Only 25% of patients on hemodialysis are even on the list for transplantation. I think we can do a much better job in that. I also think that, so clearly we need to get rid of the shortage of organs. A lot of good work and interesting work in xenotransplant, and obviously things like the implantable kidney.
I think we have time for one last question. Dr. Mensa has raised her hand.
Good morning. Fantastic talk. As I was listening to you, you mentioned it's $114 billion spent in dialysis care. And my question is, for innovation, wouldn't it be much more cost effective to spend those dollars in preventing kidney disease in the first place? I mean, we see so many patients uninsured with hypertension, diabetes, who would then down the line end up in this situation. So Just one of your thoughts on that.
So I agree with you 150%. I had focused this talk on some of the things. I gave you the one example of the KHI project. Clearly, there are many initiatives around prevention and patient-centered tools. I'll give you my own view. I think it is unconscionable that we as a society are not willing to pay $1,000 a year for treatment of hypertension in a young, often African-American male. And yet, when that same person 5 years later starts off onto dialysis, all of us, because it's taxpayer money for hemodialysis, have no problems in saying we're going to pay $89,000 a year. And in what we don't think about so much, so the financial stuff makes no sense, but more importantly, the quality of life. We have completely destroyed the quality of life and the aspirations and the earning ability and the contributions to the society of a young person. I think that's a disgrace.
I agree. Thank you.
Dr. Roy-Chaudhury, thank you for really a tour de force. So grateful for your insights and wisdom. And I know everyone in the audience agrees that the applicability beyond chronic kidney disease is very evident, and just very grateful for your time with us. And again, for your wisdom as we try to do more for the people who need us most. So thank you so much for joining us today.